81-year-old female, untreated. Complaints of pain. This is the situation. Bone quality is not very good. Underwent hemi replacement, anatomical replacement, and the patient is happy after that. Pain is elevated, and movement is as much as what she had before, because before she had the movement at the fracture site. Now it's occurring in the joint. That's the only difference. Treat them as different injuries. Young patients, restore function, preserve the head. Elderly patients, look at elevating the pain and restore function as much as possible by the methods which you are familiar with. Broadly, indications for hemi are low functional demand, poor bone quality, advanced age, vascularity of the head is compromised, and when patient is likely to undergo one surgery in lifetime. There are problems with the hemi. Tuberosity is the main thing which has to be addressed when you do a hemi. Prosthetic malposition, functional limitations, usually above the 90 degrees is less likely to get in the patient, and rehabilitation is very important in these patients. You can also use suture anchors to hold your tuberosities in position, in addition to the sutures which you take around the bone and the musculotendinous junction. This is an important slide where you look at the fracture personality, look at the age, bone quality, fracture pattern, and time of surgery. Look at the patient pearls, whether there are medical comorbidities. What's the functional recovery? Usually a functional recovery in a shoulder surgery, especially in a proximal humeral fracture, takes 12 to 18 months. Even though there is a fracture, there is a soft tissue injury, there is also an additional injury to the nerves, which may not be very evident, especially suprascapular nerve and the axillary nerve, which will take some time for it to heal. And a good functional recovery you can expect only after 12 to 18 months. CT scan and 3D reconstruction are very important in decision making, especially when you are doing a fixation. Delay in surgeries, whether non-union has occurred, a partly union has occurred, are also important to decide on the type of fixation or type of treatment. Algorithm questions you can ask is operative and non-operative. Head preserving or head replacing. When you do an ORIF, it is important that not only in the vertical plane, in the horizontal plane also you have to look at. An excessive retroversion will produce limitation of internal rotation so that he won't be able to reach his back pocket, even though he might be able to reach others' back pocket. And too much of antiversion will reduce the external rotation and in turn will reduce the abduction. So it is important not only in the vertical plane looking at varus valgus, but also in the horizontal plane, especially when you do an open reduction and internal fixation and hemi and reverse. So these 4 points, if you keep in mind, overlap these 4 points in fracture personality, patient pearls, and algorithm questions, and then you get a treatment method for all these fractures. What are the problems in proximal humerus fractures? The classification, Neves classification, AVOS classification. So there are many classifications which have been described. What is important to know is the understanding the pattern of the fracture by CT scan and 3D reconstruction. Hertel's criteria that about the vascularity of the head is still controversial. 4 years later, after Hertel described his criteria in 2004, Bastian came out with a paper which tells you that the vascularity of the head is not dependent on avascular necrosis or the fracture collapse. So in a young patient, even though the head appears avascular by Hertel's criteria, you can go ahead and fix it. RCTs are very confusing as far as the proximal humeral fractures are concerned, because these are the ones which usually mislead, and especially when you go into each aspect of an RCT, then you will understand that there is some flaw in comparing two groups. Geographical variation, if you look at North America, this pendulum is swinging more towards hemi and reverse shoulder in an elderly patient, and more towards fixation in European countries, whereas in India, it still has geographical variation depending upon the surgeon's capability and also depending upon what are the facilities available in your setup. This one, greater tuberosity fracture with anterior dislocation, old, unreduced, came after 8 months in an 81-year-old lady, and this is the CT scan, and she underwent, because of the cuff problem, she underwent reverse shoulder, and this is her movement after 6 months. And the patient is quite happy to get 90 degrees of movement, which she never had before she underwent surgery. In summary, fracture in young need fixation. Fixation is a soft tissue procedure with bony alignment. Elderly osteoporotic comminuted fracture needs hemi if the cuff is intact. Reverse shoulder when indicated, especially there is cuff problems or you expect that the tuberosity is not going to heal. Thank you very much. Thank you for the opportunity.
Thank you, sir. Dr. Srinivas Kashyap can.
Thank you, sir. That was a wonderful talk. So, do we have Dr. Michael Mackey?
Yeah, he's one more. He had called me from difficulty joining. He's already he's there.
Hello, everyone.
Yeah, hello.
Oh, you are on time.
I'm terribly sorry. I'm having trouble with the Zoom package was not up to date, so I had to download and install a new Zoom. Anyways, I should be good to go.
Yeah, actually, we finished the second talk, Prof. We'll be going back to your talk. You can go with your proximal humerus fracture talk.
All right, let me get that loaded up here. One second.
While we are waiting for him to get in, I'll just give a short introduction. Dr. Mackey is truly joined in orthopedics. He has almost 30 years of experience in orthopedics. He obtained his MD and his orthopedic training from the University of Toronto, and then completed a fellowship in orthopedic traumatology at the MGH under the legendary Jesse Jupiter. He's a recipient of many awards, to name a few: the Edwin G. Boville Award multiple times, then the Near Award from the American Shoulder and Elbow Surgeons, the Robert Salter Award for Teaching Excellence, several awards for teaching excellence. He has published not only several papers, but also multiple high-impact randomized control trials over the years. In 2017, he accepted position as the professor and chair at the Department of Orthopedic Surgery at the University of Arizona College of Medicine, Phoenix. He was the president of the Orthopedic Trauma Association in 2020. He's a reviewer of numerous peer-reviewed journals and the editor of Journal of Orthopedic Trauma and elite reviewer of Journal of Bone and Joint Surgery. It's a privilege to have you today, sir. And the floor is yours.
Thank you very much. Thank you. I apologize for being a bit late. So let me just try and get on here and share my screen. Here we go. Now, can you see that okay?
Yeah, we can see your screen.
The screen's good. Okay, so I'm going to speak about proximal humeral fracture this morning based on tuberosity fixation, which is a bit of a different type of fixation we've seen recently. And I'd like to very much thank the organizers of this meeting for the opportunity to speak. It's a real privilege and honor, and we'll do our best to have some fun and learn a few things here this morning. So if we look at modern randomized controlled trials looking at operative versus non-operative fixation of older patients with proximal humeral fractures, we see that rather disappointingly, there's not a lot of difference between the two groups. These three studies, including the PROFER study, which was a fairly high-profile randomized trial, showed that there really was not much difference in the outcome scores between these various groups, between the surgical and the non-surgical groups. Well, why is that? Well, we know that there are a lot of successes with proximal humeral plates, but we also know that there's a lot of failures as well. So we have loss fixation, we have tuberosity pull off, we have screws pulling out, backing out, etc. So if you look at those studies, the group that had surgery, that had fractures heal in a good position, are the best patients in those studies. But we can't do that reliably. The complication rate remains high with surgical fixation, and those numbers bring the overall average down in the surgical group. Well, how do we improve upon that? Because even in 2021, this is still an issue. When I was at the American Academy, and this is the last time we had a live meeting, I asked the audience, what issues do you have with the proximal humeral plate that you currently use? And you can see that tuberosity fixation and screw penetration to the joint were two of the biggest problems that people had, especially tuberosity fixation, where you can lose the GT or the head spins off into varus. And that was a significant concern for a lot of people in this kind of setting. This is a case of mine where you can see we have a nice fixation of the tuberosity. Everything looks good. The plate's a bit higher than usual because there was a large DT piece. And I usually often put locking sutures through the rotator cuff and onto the plate as well. And we did that in this case as well. But despite all those efforts, you can see the tuberosity is pulled off. In an older patient, this usually means conversion to a reverse arthroplasty. In a younger patient, it's a major disaster. It's very difficult to salvage this type of situation because of the difficulty in getting the tuberosity back down and getting the cuff reattached to it in this kind of setting. So this remains a problem in my hands and a lot of people's hands with this kind of fixation. This is a picture from Gilles Walsh, who's a famous French shoulder surgeon who's really written a book on a lot of electives and rotator cuff procedures and shoulder surgery. He's showing here that with the standard humeral locking plate, there's really no good fixation of the tuberosities, either at the back with the greater tuberosity or in the front with the lesser. The plate's on the side, the tuberosities are in the front and the back, and that's very difficult fixation in this kind of setting. And we all suture the greater tuberosity back down. We've been taught to do that. I do that as well. The problem is that if you look at it biomechanically, those tension relieving sutures, the ability to put the cuff back, really doesn't seem to improve the stability of a 3 or 4 part proximal humeral fracture. And there's very little mechanical data that says, yes, this is a good thing to do. So we all do it, but really, unfortunately, it doesn't make much of a difference to the overall strength of the construct. And here's a recent paper out from a group in Germany, which is a well designed study looking at over almost 100 patients. And they found that tuberosity pull-off was a significant issue and that a lot of these patients had problems. The complication rate in this modern series from a good group was 37%, and 27% required revision surgery. This is a rate much higher than what we'd anticipate in other areas. And they said that if your GT pulled off, that happened 1 time in 4, and the relative risk for a poor outcome increased 3-fold. So it really is a bad issue when this happens. Back in the days when I used to use a small cloverleaf plate, I used to take a plate and contour it around the tuberosities, almost like a hook plate. And this, of course, can potentially produce impingement, but I think we'd all rather have the picture on the right where the tuberosity is back down where it belongs and held there securely than the picture on the left where you know this is going to be a very bad outcome for this patient on the left-hand side. With all those thoughts in mind, we designed a plate, and I do have a financial interest in this plate by way of full disclosure, and my financial disclosures are on the American Academy website. We designed a plate that has a hook on top and has flanges to control or corral the tuberosities to hold them in place better. It's just like a proximal humeral plate. It has all the advantages of that, locking screws, calcar position screws, etc. But it also has a combination of flanges, and you can choose the combination that you'd like to use to hold the tuberosities in place better and rely more on tuberosity fixation from the flanges rather than just pure screw fixation. And these plates will be contoured in situ once you have them applied to make things better. We did a biomechanical study looking specifically at how well the greater tuberosity is held by these plates. And you can see here, this is a pictorial of our mechanical study. On the left-hand side is the hook plate that ITS produces. In the middle is the standard plate, and then you can see x-rays on the side. You can see the obvious mechanical advantage here, theoretically, from the hook holding the tuberosity. This is our experimental model here. And these are our findings. You can see that the ITS hook plate had clear superiority, overall almost 2.5 times more stability, if you want to look at it in that way, compared to the regular plate for holding the tuberosity down. So there's a really dramatic biomechanical advantage in holding this plate in place and holding the tuberosity down in this kind of setting. This is an example of a relatively simple, and I'll show you some clinical examples now. This is a clinical picture of a patient with a relatively simple fracture. It's not really that displaced, and you can see it's off the back like usual. This is the operation we did. You can actually use the flanges to compress the head together, so you're more reliant on the position of the plate and the flanges than pure screw fixation in order to get fixation in this kind of picture. And you can use that superior hook if you use it for better fixation. You can really compress that down. When you put that screw in, it holds things down nicely. This is another example of a 58-year-old female with an impacted valgus fracture. The large greater tuberosity fragment, you can see that would be a major problem in terms of fixation and holding that fixed. And you can see how the hook actually digs right into the tuberosity, and the front and back flanges hold the tuberosity in place. You can also see that we've also been very careful to adhere to the other basic principles in this situation. We put a screw in the calcar. That's very critical. We get a good reduction. We don't leave it any residual varus. In addition to all those standard things that you do with hook plate, we do that here. But also, you can see how the front and the back flanges can hold the humeral head in place, so you don't get translational problems like you do with standard plates where you can malrotate or maltranslate the head. That lady at 8 weeks with good healing and 120 degrees of flexion. I'm going to show you a case, and people always ask me about impingement. What about impingement? That is a bit of a concern. This is a patient who had a severe fracture dislocation of the shoulder. You can see there's a large GT fragment there, and that's a major concern as well. This is the fixation of that patient with the hook driven right into the GT fragment. This is the patient healing, subsequent healing down the road once the axillary nerve palsy recovered. And you can see here, this patient has full rotation. There's no impingement of the flange of the plate. And that's a major concern in the past, where you can see that the flanges may impinge a bit on the articular surface, but if you leave the flanges just shy of the margin of the articular surface, then you get full rotation without impingement with these plates applied. So to conclude, I'll say that most patients, especially the elderly, can and should be treated non-operatively. We all know that. Currently, 3 modern randomized trials in general do not show significant improvement with fixation compared to non-operative treatment with the standard plates that we have. In the series I showed from Germany, from a good solid group using modern techniques in 2021, showed a 27% reoperation rate. We still have significant issues in fixing these fractures with the implants that we do have. If you do choose to fix them, there are several established principles that are important to maximize success. Make sure you get a good reduction. Make sure that you use a calcar screw. But we think this newer plate that we have designed also has some significant advantages for fixation when it's based on the tuberosities. Thank you very much for your attention.
Thank you very much, Professor McKee. That was wonderful talk. I just have one question. So,
Sure.
What are the chances of impingement with this plate?
So we don't think the plate impinges at the front or the back very much. So you can the flanges of the front and the back are well shy of the articular margins. So that's not an issue. There is the potential for impingement superiorly, and I agree with you there. So far, when we put the plate on and you really make sure that the flanges are driven down into the bone, the rate of impingement is very low. And so we have only removed 1 or 2 of these plates out of the first 60 that we put in. And I'd much rather have the situation where the tuberosity is healed in place and there's a bit of impingement rather than having a tuberosity pull off. If the plate impinges, you can come back and take it off as long as things are healed. It's an easy solution. If the tuberosity pulls off, then it's a major disaster for the patient. So we have removed the plate for impingement, I think, once, maybe twice out of 60 patients so far.
Great. Thank you. Any questions?
So, Professor, what are your indications for this plate over a regular proximal humerus plate? When would you rather use this clover plate, hook plate?
Well, we have different models, so that I use this plate for most fractures now. The full bore plate with all of the flanges and the hook on top I use for 4-part fractures in people where I'm trying to fix the fracture and not replace it. So a 50, 60-year-old 4-part fracture, those are the primary indications for the plate. If we have a younger patient with better bone quality, a 2-part fracture, then probably a standard plate is reasonable. But for the older patient with the 3- and 4-part fractures, this has become our standard plate for fixing these fractures. And it's basically eliminated GT pull-off. We have complications like everyone else, but pull-off of the tuberosities is not one that we see anymore with this plate. It's very encouraging that way.
I have a question,
Sir,
Dr. Mallikarjun here. This question is for all the panelists. Do you consider primary decompression of the acromion when you use the plate, proximal humerus fracture? Any experience on that? My question is that any primary decompression of the acromion is useful when you're suspecting impingement. Any experience on that?
Personally, if there's a very prominent acromion, or especially if I'm doing a deltoid split approach, so I do the deltoid split approach on occasion, and in those situations I have used, and you can use this plate through a deltoid split, by the way, if you find the acromion is very prominent in that kind of setting, then yes, I have used a primary acromioplasty with a microsagittal saw to help decompress that space. I have done that. Not so much the delta pectoral, it's more difficult to do, but I have done that.
Professor Mackey, what about biceps tendon when you use this plate to hold the lesser tuberosity?
So most of the time, in anyone over about 50 years old now, I'm going to take the bicep tendon when I do the operation. So I do a tenodesis pretty well every time in someone over 50 now. The biceps just seems to be a pain generator. It's not that important, et cetera, et cetera. So in general, I take the biceps tendon in older patients now. If you want to leave it, and once you reconstruct the fracture, the biceps will run in a groove underneath the front flange of the plate. And so the plate goes over top and the biceps will run underneath that flange without too much impingement. And I've got a video of that in one of my cases, so that if you do reconstruct the proximal humerus and you want to leave the biceps alone, you can do that and nothing bad seems to happen. It's quite acceptable. So you don't have to take it every time. How about yourself? Do you routinely take it or leave it in older patients?
Older patients, I keep it. I don't take it out unless it's damaged. Second question is it these are the alternatives, or you go with the same type of suturing techniques, and this is an addition to the suturing technique in proximal humerus fracture?
So I still use the suturing technique most of the time, and this is addition to it. And that's the way our experimental biomechanical setup was made. But I'm not sure it adds much, frankly. If there's a hole or a rent in the rotator cuff, of course I repair that. So I have a nice, good sleeve on top, and then put the hook in the tuberosity, and I put the sutures to the plate. But I'm beginning to think now that it's not that big an important difference, in that lately I've been doing it less and less, and I don't think it makes any difference biomechanically. And that's what our study would show. So you should have the confidence to believe in your biomechanics sometimes. And I think it's nice to do it, but I don't think it adds much. If the cuff or the tuberosity are multiple fragments, by all means make them one so you can put the hook in it. But for an isolated GT fracture with no big cuff tear, I don't think it's necessary anymore to do that, frankly. Just waste time.
Professor Mackey, I know that you are more towards hemi and reverse as far as older patients are concerned in proximal humerus fracture. Does this plate has changed your views in older patients?
So that's an excellent question. And so the answer is yes. I feel more confident now fixing more difficult fractures in an active 65-year-old. So if you have a 65-year-old who plays tennis or who plays cricket, and which I still don't understand how you score in cricket, but we'll leave that for now. Or they're a sport or athlete, or they like to work on their car, et cetera. It's very, in North America, that person, if they're healthy, they might live another 30 years until they're 90 or 95. A reverse is not going to last that long. Yes. And so in that very active individual in their 60s, this plate gives me more confidence fixing that tough fracture that I don't want to do a reverse on for that specific reason. If they're 80 and they've got diabetes and heart disease and a terrible fracture dislocation, yeah, reverse for sure. But that gray zone area where you You know the reverse is going to be good for 5 or 10 years, but you know down the road they're going to pay the price, especially if they're very active. Then this has changed my practice for that specific group. That's an excellent point.
Yeah, thank you very much.
Professor, may I ask you a question, Dr. Rajkumar here?
Yes.
This question is for both Dr. Sharath and Professor Mackey. I see in some instances your proximal humeral fixations will be not giving optimum outcome, and sometimes you have seen that your screws will go into the joint and there will be a collapse of the head itself. So do you routinely suggest that we should use a biological graft or biological augment to supplement your fixation that you're talking about, whichever plate you want to use, whether it is a fibular graft or a iliac crest graft? Do you suggest that we should routinely use, or it has to be used in a particular case only?
Dr. Sharath, did you want to address that?
Yeah, I don't have much experience with the fibular strut graft. Especially, we have used in few cases the fibular strut graft on the inside, especially when the patient is younger and the proximal fragment is quite small, and you need a strut to hold it so that it won't get into varus position. The second important point is avascularity and collapse do not go together along with your Hartel's classification of vascularity. Most of the predicted avascular fragments may not undergo avascularity and collapse when you see them over a period of time. So what you need is a good calcar screw to hold it in position. A greater tuberosity position is very important. Once the greater tuberosity slips off, then everything goes haywire. You get varus, you get penetration of the screws, and you get a collapse along with that.
I agree completely. So number one is I don't use the fibular strut grafts for fracture cases. I think the information now that's available, including a couple papers recently, show it in general, it doesn't make that big a difference to outcome. I do use it for non-unions though. So if there's a clear-cut surgical neck non-union and the head's one piece, I do use it for non-unions. I found it very effective there, but not for fresh fractures anymore. Secondly, as Dr. Sharath points out, if you can keep the head in the right position, a lot of this cascade of bad things doesn't happen. And I agree completely with that. And to avoid those things, the plate we use helps cradle the head together, so you don't rely so much on those screws. So the superior screws, which are often the ones that penetrate, I leave those a bit short. Make sure you have a calcar screw, make sure you have no varus, and make sure that you don't let that varus collapse occur by holding the GT down. If you do those things, our rate of screw head penetration has been very low. In fact, I don't think we've had a single case with that issue, and that's a major issue in other series. So you can reduce that rate of screw penetration by doing the standard things, which is good reduction, no varus, calcar screw or screws, and make sure that you don't let the GT pull off. I think there's probably a role for calcium phosphate cements or morselized allograft in some of these cases where there's a big hole or defect. Just there's no compelling evidence at the present time in a good prospective study that makes a difference at this time.
Michael, one of my colleagues wanted to ask a question that how easy to put this plate from the deltopectoral approach, or you specifically use deltoid splitting approach?
My standard approach is the deltopectoral approach. I've toyed with both, and especially if there's pathology around the back, the big GT pieces pulled around the back, the deltoid split can help you. There's a good randomized trial from the doctors in Montreal, Canada. It's in the JSES within the last year or two, looking at deltoid split versus a deltopectoral. And they were strong proponents of the deltoid split. And what they found was that the deltopectoral approach actually gave a better functional outcome and a better reduction and a lower complication rate. So for me, that has changed my practice. I've gone back to using mostly deltopectoral. I do have slides I didn't show for the sake of time that you can also use this through a deltoid split approach if you wish. That's not a big deal. It's the same principles. It's a little tighter getting the plate in for sure. And I wouldn't maybe do it the first time I use the plate, but you can do it through a deltoid split as well. But generally speaking, deltopectoral for me.
Mackie, generally the greater tuberosity that escapes those are the comminuted ones. not the big chunk ones. Do you, by your plate, do you hold it specifically, or?
I try and suture everything together so I have one piece with the cuff. So I've got a sleeve of tissue with the tuberosity fragments there. And then basically I pick the one biggest piece and put it down there. In the cases we've done, that has been successful every time except for one case. In one case, I kept half the tuberosity down and the other half pulled around the back. That patient has not got as great a result as the other patients, but it's not a disaster. So we kept the main piece there, but some of that posterior sleeve pulled around. So he's got weakness and impingement in external rotation, but he can still flex well. And so it's not ideal, but it's better than having the whole sleeve of tissue pull off. So that does happen. It's happened to us once, and it did affect the result, but it wasn't a complete disaster, which is what happens when the whole tuberosity pulls off. So it's a very good question.
Professor Sharath, this is another question to you from the audience. Do you have any age cutoff for doing a hemiarthroplasty? Because a hemi is going to be entirely almost dependent on the function of the union of the tuberosity. So even if you have a intact cuff, do you sometimes prefer to do a reverse shoulder rather than a hemi?
Yeah, that's a difficult question too. We can, in our setup, we can't have a reverse shoulder as a backup. We can only have a hemi as our backup. So it's only between the fixation or the hemi. So hemi, it is very important to analyze the tuberosities because they are the ones which determine the outcome of the hemi. Apart from comminuted, yes, there is many methods which have been described depending upon the processes you use, the ways to fix them with the sutures, and hope for the best. That is the tuberosity. And apart from that, maintaining the tuberosities in position. And the second thing is having a good version. These are the two important factors for the success of hemi replacement arthroplasty. And choose your patient. Most important is choose your patients with comorbidities, not high demand on the shoulders, and not good quality of bone. These are the patients who will do well when you select them from.
How do you plan for the height of the prosthesis?
Depending upon the position on the table, you see it so that you see the movement, whether it is subluxating in that position, push and pull, and see to it that you get to the original.
Dr. Srinivas, can I ask you to your case so that we can have more discussion?
Yeah,
Sir Mackie,
If I just add, I agree with that completely. One thing I might add is it's become very popular in North America now to use a platform stem. So we could argue hemi versus reverse all day long, but one thing that's become very and critically important is to use a platform stem. So if you do a hemi and it doesn't work, then you can convert it to a reverse without having to dig the stem out. And that's made a big difference going forward.
I'd like to welcome our panelists, Dr. Srinivas Reddy, Dr. Anup, and I'd like to request Dr. Sharath Rao and Professor Mackie to be online. I'll present few cases. This is a 35-year-old male, fell from a two-wheeler, road traffic accident, in severe pain and not able to use the limb. Sir, Sharath Rao sir, how do you go about it?
Take an axillary view, scapular Y view, and a CT scan.
Yeah. So all the time, when we have a severely painful limb, how to get a proper?
So if you are sure that you are going to get a CT scan, I don't think you need other two X-rays if it is painful.
Okay. So, but in the periphery where you don't have CT scan available, how do you, what is your suggestion? Just for the discussion's sake.
You could get a Welper view. Would not be very painful.
Yeah, that's great. I think that's not that painful, and at the same time we get some information. So that is the CT scan here, sir. I'd like to play the video. Sorry.
you can get a hint on the AP film that something's not right, that with the head, that looks like it's out the back on the plain film there.
Yeah. Yeah, Professor Mackey, please.
No, I'm just saying, even on the plain film, you can see something doesn't look quite right with the head, so it's not surprising to see it's out the back. And so they have a posterior fracture dislocation of the shoulder. It looks like there's a fairly significant impaction fragment on that, and the LT looks like it's broken as well. So this patient will probably need an open reduction to have this put back in. And I think the key thing on the approach here is to not take off the subscapularis, but to use the LT and leave the subscap attached to it as a separate piece in your approach, and you can plug it in the hole when you fix the fracture on the way out. So I would use a deltopectoral approach to fix this and make sure that I maintain the subscap attached to that lesser tuberosity fragment. I think you can see on the CT scan there.
Great, great. So, Dr. Sharatra sir, so anything to add?
No, only deltopectoral view, deltopectoral approach, and greater tuberosity is anyway fractured. Lesser tuberosity is likely to be fractured. Use the suture anchors, open them, and you can see the raw fracture surface in front of you. Use a small chance to put into the head and get it